Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms, Marcus at Home welcomes Professor Johannes Mann in Munich, Germany, and Professor Indranil Dasgupta in Birmingham, UK, with whom we would like to discuss in an academic debate the pros and cons of the novel KDIGO blood pressure targets for adult patients with chronic kidney disease, CKD, not undergoing dialysis. Dear Dr. Mann, dear Dr. Dasgupta, it's our pleasure to welcome both of you. We're very honored that you accepted our invitation for this debate.
Thank you.
Professor Johannes Mann is a nephrologist in Munich, Germany, and professor of medicine in Erlangen, Germany. And he's the co-chair of the work group that published the 2021 KDIGO guidelines on blood pressure, which recommended a target systolic blood pressure of below 120 millimeters of mercury when tolerated, using standardized office blood pressure measurements in adult patients with chronic kidney disease not receiving dialysis. And for our colleagues in Austria, Switzerland, Germany, who would like to have a German version of this talk, we had the pleasure to host Professor Mann last year, and we can just link the German version to this video. Dr. Indranil Dasgupta is a nephrologist at University Hospitals Birmingham and professor of medicine at the University of Warwick. Dr. Dasgupta has recently criticized the KDIGO recommendations in a rebuttal article published together with Professor Carmine Zoccali, former president of the European Renal Association from Reggio di Calabria in Italy. And in this rebuttal, they claimed that the KDIGO recommended target systolic blood pressure below 120 millimeters of mercury for CKD patients would be inappropriate in the majority of our patients and even potentially harmful for patients managed in routine clinical practice. My co-moderator today is Andreas Kronbichler, Cambridge, UK, Innsbruck, Austria. And before switching the mic to Andreas, I would briefly introduce the rules of this debate. We will first invite Dr. Mann to give his arguments for the tight KDIGO blood pressure targets, and then Dr. Dasgupta to give his arguments against these targets in 2 10-minute speeches. Afterwards, Dr. Mann and Dr. Dasgupta are invited to short rebuttals of no longer than 5 minutes or so each. And finally, Andreas and I may each raise a maximum of 3 final remaining questions to each expert. So, Andreas.
Yeah, Gunnar, you have already alluded to everything what I can say now. So I would like to invite Professor Mann to start his 10 minutes presentation with arguments pro target of below 120 millimeter mercury.
Yeah, dear friends, thanks for inviting me to this pro-con debate. As a chairman of the work group that published the KDIGO guideline, I will present the pro arguments. And as Professor Heine said, this is an academic debate, but please don't take everything so seriously. There will be some jokes. And to start with, to keep this at level playing field, I will give the talk in English. And Dr. Dasgupta promised to give his talk in Bavarian, which will be interesting and which will enlighten the debate, I'm sure. We should not talk too long, and therefore I have prepared the slide in the whole talk in one slide. SPRINT, and what I'm saying is mainly based on SPRINT, is targeting standardized office blood pressure below 120. And in that trial, there was an overwhelming benefit of the lower blood pressure target of less than 120 as compared to less than 140, including in those with CKD. Please remember that the SPRINT trial ended early because of ethical reasons, because of overwhelming evidence of benefit of the lower target. That is really rare, and is also very rare that in single blood pressure trials, if I may call so, there was a benefit, a huge benefit actually, on mortality in those with and without CKD. Very similar reductions in harm with a systolic blood pressure target below 120 was demonstrated in the standard glycemic arm in a cohort. And that's what we are aiming at nowadays in the treatment of diabetes, a standard glycemic arm, not an intensive arm. We're also saying that basing any clinical decision on non-standardized clinic blood pressure is, in our view, indefensible. And we have to try to implement standardized measurements in every clinic. The KDIGO guideline explicitly requires a shared decision-making process. That is, when you talk to your patient and explain to him what you're doing with this patient and his blood pressure, you have to tell him about the results of SPRINT and have to offer him that treatment, providing an extensive survival benefit and also a cardiovascular benefit. Now, this is SPRINT in one slide, so to say. Remember that the control group, that's the upper line, the standard treatment was well controlled. Mean blood pressure definitely below 140. And if you look at a lot of outcome trials, that's a very good result. And lowering blood pressure even further to a target below 120 resulted in less than 90% less cardiovascular outcomes and a 26 relative risk reduction in mortality. That's huge, it's significant. It's based on that blood pressure difference. And to stress it again, it was compared to a well-treated group. Now, what are the arguments contra the blood pressure goal of less than 120 of the KDIGO guideline? And Indranil and Kronbichler have published really a wonderful paper in hypertension. I like this paper and I disagree with almost any line. He has summarized his points, and I will answer to some of these points. He's saying that it's based on a single trial. That's true. It's based on a single trial, but what else do we have? That's a problem. We have 3 further trials only that examined target blood pressure in patients with CKD not on dialysis. The African-American study in kidney disease compared a mean arterial pressure. MDRD also compared mean arterial pressure, and who in the world is using mean arterial pressure these days? We're all using systolic and diastolic. Mean arterial pressure is diastolic plus a third of pulse pressure. Nobody's using it. RAIN-2 was woefully underpowered, and the other trials were also woefully underpowered to test MACE, major adverse cardiovascular events, and to test cardiovascular death. Remember that the patients we're looking after with CKD before dialysis mainly die before reaching dialysis and mainly die of cardiovascular disease. And therefore is of utmost importance that we really look at MACE, look at survival, and only thereafter look at renal outcomes in these patients. Another argument is that if you look at the CKD patients and try to reach a blood pressure in the range of 120 systolic, measured by standardized blood pressure, this may increase the risk for adverse events, as Indranil is saying, in the multimorbid, frail, and elderly CKD population, especially if based on routine blood pressure. Well, we are saying don't use routine blood pressure when you are basing management decisions in hypertension. If you're doing something else with the patient, okay, measure it routinely, but not when you decide on the patient's management of blood pressure. Well, the elderly CKD population provided exactly the same results as the younger patients in SPRINT, and there was a huge elderly population. They also had a big advantage for their head, and that's important. Yeah, they had less strokes, much less strokes, also true for our cohort, much less strokes with lower blood pressure goal in a cohort and in SPRINT, and they had less development of dementia and of impaired cognition. And believe me, you do not want to have impaired cognition. That's serious. Now, how about other adverse events? Well, injurious falls. Do these patients with intensive blood pressure goal have more falls and come to the emergency department, have their hip replaced? No, they actually have numerically less, but they have the same. Yeah, if you look at the p-value, the hazard ratio, no difference whatsoever. Syncope, no difference whatsoever. In this case, the numbers are somewhat in disfavor of the lower blood pressure goal and hypertension. Well, hypotension, hypertensive symptoms, you obviously have more with the lower blood pressure. If induced by drugs or spontaneously, that's the case. More AKI with the lower blood pressure goal, okay. But those cases were, one, benign, and second, were always reversible. So no major aspect here of adverse events. Then last point, for our colleagues, it's probably difficult to digest that based on the same data, some committees recommend a target below 120 like KDIGO and others higher targets. And Indranil is saying that KDIGO is an outlier among hypertension guidelines. And this, I say, well, it's probably a post-Praxis view of the world or a post, let's say, a monarchistic view of the world. Because here's KDIGO, targeted less than 120 systolic. And here, a lot of space for NICE. That's the English version of Guideline Commission. And that committee is saying systolic below 140 for the non-diabetic with CKD, and for the diabetics, a somewhat lower goal. But please tell me any trial that has investigated CKD, these targets. There's nothing. There's absolutely nothing. This is American, so the only international guideline here is EAC. However, what this slide does not show, and that's what I'm saying, that's it's a post-Praxis view or a monarchistic view. There are other parts of England which definitely disagree with NICE. Sorry, different parts of the United Kingdom. And now I come to the largest countries in the world, part of the United Kingdom, Australia and Canada. Queen Elizabeth is the Queen of Canada, my second home country, and is the Queen of Australia. And in those countries, less than 120 based on standardized blood pressure, or if tolerated, is recommended. And I particularly value the Canadian guidelines, which are published every year now for the last 20 or 30 years, with the new evidence incorporated with a clear mechanism how this guideline is published. It's not by the GOBSAT function, good old boys sitting at tables. It's a very good guideline. And in the Canadians also showed that implementing standardized measurement of blood pressure in general practitioners' offices is possible. With that, I hope I didn't go much over 10 minutes, and I thank you for your attention, for having presented in part a few aspects of the KDIGO guideline on blood pressure in CKD before dialysis. Thanks a lot.
So with this, we would like to hand over to Dr. Dasgupta to have this presentation of around 10 minutes and present some of the monarchy countries, at least the UK opinion.
Right. Thank you, Hans. Excellent presentation. You have the advantage of knowing my my views on this, so which is good in a way. So it makes it slightly easier in some ways and more difficult in some ways in other ways to defend my argument. So what I'm going to do in the next 10 minutes, hopefully I'll be able to do in 10 minutes, that KDIGO blood, I would argue that the blood pressure target of less than 120 millimeter of mercury systolic for CKD is inappropriate in routine clinical practice. So the first point is that it's a weak recommendation based on low quality evidence. Now, this is not what I am saying. This is what the guidelines development group said. If you look at the evidence grade against this recommendation, it's 2B, which means it's weak recommendation based on low quality evidence. But I would argue it actually should be downgraded to 2C or even 2D, and in the next few slides. So this is sprint trial. Hans has already described this, so I'm not going to go into this. So the KDIGO guideline, the target, is based on the sprint CKD subgroup analysis. Okay, so, and as you can see, unlike sprint, the main trial, there was no benefit in the intensive group in terms of composite MACE, cardiovascular outcome, or the main kidney outcome. I'm not going to describe further. There was, however, benefit in terms of all-cause death, in that there was 28% relative risk reduction in people or participants that had that were in the intensive control group. Although there were significant numbers, over 2,500, sprint was not powered for subgroup analysis by the as suggested by the sprint investigators, and also admitted by the KDIGO guidelines group. Furthermore, this is a post-hoc analysis of sprint that looked at eGFR and the risk-benefit profile. And as you will see, the people with GFR below 60 did not benefit in terms of cardiovascular composite outcome at all. And similarly, there's no benefit in them in terms of albuminuria or GFR-based renal outcome. On the other hand, there was increased incidence of acute kidney injury in those with GFR below 45. And in fact, in the sprint trial, we see that as over time, after 6 months, there is more rapid decline of kidney function in the intensive blood pressure group. So Hans said, "There's what have we got? We haven't got enough evidence to base our recommendation." But that doesn't justify recommending a target based on a weak or inadequate evidence. So here is a meta-analysis of pooled individual data from 4 RCTs related to CKD, ASK, ACCORD, which is a diabetic trial, MDRD, which we know about, and SPRINT. So comparing intensive control versus standard control. And as you'd see, there was absolutely no benefit in terms of all-cause mortality in the pooled analysis for intensive blood pressure control. And similarly, absolutely no benefit in terms of cardiovascular outcomes. And this is something that Hans alluded to, but when you exclude patients that have GFR over 60 and those who are in the intensive glycemic group, there was some benefit, statistical benefit, in terms of all-cause mortality, but not in composite cardiovascular outcomes. So we have data, and there are 2 other, which I haven't got the time to go through, 2 other meta-analysis showing similar results. So that's my first point. My second point is that the recommendation is not generalizable to the majority of people with CKD, because, as you've already said, the recommendation is based on sprint subgroup analysis, but sprint excluded people with diabetes, those with age below 50, people with CKD with proteinuria over 1 gram, eGFR less than 20. In fact, there are a handful of patients in stage 4 CKD in the study, adult polycystic kidney disease, and glomerulonephritis treated with immunosuppression. So you will agree with me that it rules out majority of people with CKD in the SPRINT trial. And we know that diabetes is the commonest cause of CKD across the world, all over the world. They accounted for over 40% of people with CKD. So I will argue this recommendation does not apply to people with diabetic kidney disease. And in terms of diabetes, we talked about the ACCORD trial, which looked at intensive blood pressure control in type 2 diabetics, and exactly similar design with similar target. And arguably, there are people with significant CKD were excluded from the trial. But as you will see, across the board, there is no benefit in terms of primary outcome of composite cardiovascular endpoints, non-fatal myocardial infarction, death from cardiovascular disease. However, there was some benefit, 41% relative risk reduction in terms of non-fatal stroke. That was only in the primary analysis. That's the only benefit that was seen for diabetics. My third point is that this target is hazardous, especially if applied to routine blood pressure measurement. And it's not me, again. This has been suggested by the guidelines development group. Let's look into it. Why is that? Because we know there is poor correlation between routine and standardized office blood pressure. So this is a study that Rajiv Agarwal did after SPRINT was published. And he estimated that the mean difference between routine blood pressure and standardized office blood pressure is around 13 millimeter of mercury, with a wide limits of agreement. And in fact, when you look at the analysis from SPRINT, post-hoc analysis from SPRINT comparing routine blood pressure, and mainly actually from the centers that had routine electronic records of routine blood pressure measurement, they found similar, 5 to 15 millimeters of mercury difference between standard and routine blood pressure. So what does that mean? That means that there's a potential risk of overtreatment, and what are the risk of? Postural hypotension, recurrent falls and fractures, and we know falls and fractures has huge human and societal and health service cost. Acute kidney injury, stroke in those with low carotid reserve, rapid decline in GFR in those with renovascular disease due to lower perfusion pressure. And of course, as again, Hans has already alluded to, our patients are frail, multimorbid, and on multiple medications, and at much higher risk. Now, Hans has shown figures. That is not the case in elderly people in SPRINT, but I would say to that is these are selected patients within a clinical trial. These are not your or mine patients in the clinic that are much frailer, and they're often hugely multimorbid. The other potential risk of low blood pressure is to driving diastolic blood pressure too low, which we know is associated with higher cardiovascular events, simply because there is reduced diastolic filling or coronary artery filling during diastole. I won't go into the details of it. So as Hans said, and I agree completely with that, the standardized blood pressure measurement is the way to go forward, because we need accurate blood pressure to be able to diagnose, monitor, and titrate treatment for hypertension. But the problem is implementation of standardized blood pressure measurement is challenging. And why? Because it requires significant resources. It requires additional space and nurse time, ensuring use of validated machine, which you should do. I'm very much in favor of it. Requires restructuring of outpatient clinics, needs staff training, which is not actually has been shown, and I can show you the data if I have time, that how difficult it is to train staff to take standardized blood pressure measurement. And it has been estimated the extra time that is needed per patient is between 7 to around 10 minutes. So that adds 10 minutes to the time that you have to see a patient, which is, it's in a busy nephrology clinic in large centers. Time and space are constrained, and it's going to be extremely hard to implement this. And in fact, I know from my experience in the UK, has been found by many centers very difficult to implement. So it is difficult outside of specialist hypertension clinics. We do it in my hypertension clinic. We have been doing it since 2014, actually. And routinely we do that, but it's possible because the high specialist hypertension clinic, and similarly in research. But it is more difficult to implement in primary care. Our primary care colleagues are in severe time pressure. They get only 10 to 15 minutes to see a patient. In the UK, about 10 minutes, and they haven't got. There's no way they can implement this in routine care in primary care. But mind you, most of our patients with CKD are in primary care. And the ones that are likely to benefit, as you've seen from before, from low blood pressure target, are people with CKD 3, 2, 1, 2, 3, not 4, because there are very few patients, handful of patients with CKD 4 in SPRINT. And furthermore, this is a global guideline. This is not for developed countries. In developing countries where there are resource-poor settings, this is going to be nearly impossible to implement. Polypharmacy is a huge problem in CKD. A recent German study, I'm sure you're aware of, has shown that in people with stage 2 and 3 CKD, over 60% of them are on more than 5 medications, which is the definition for polypharmacy. And we know polypharmacy is associated with lots of problems: increased adverse reactions, drug interaction, non-adherence is the commonest cause, and we've shown this ourselves, that in the commonest cause of apparent treatment resistance is non-adherence, poor functional status, cognitive impairment. And it's also a huge cost to the health service. And in the UK, it is estimated in 2010, there were 300 million pounds are wasted on medications because people were not adhering to their the prescribed treatment. They were collecting prescription, but they're not using it. Now, I also believe strongly that the target is not achievable in the majority of people with CKD. Now, this is, I would give you this example of, this is a study, which is an estimate essentially based on NHANES data of percentage of people that achieve different blood pressure targets, KDIGO 2021, ACC, AHA, and KDIGO 2012, so 120, 130, 140. And that was extrapolated onto 35.3 million adults with CKD in the US. And what have they found? That 70% of the people with CKD in the US will have a blood pressure over 120, 50% over blood pressure of 130, and 34% over a target of 140 millimeter of mercury. You've seen this slide already, so I won't go further into it. The only thing I would say to what Hans has said, that the Canadian Australian guidelines that you referred to, Hans, they also have, with their standard the target for standard blood pressure measurement, they also mention a target for routine blood pressure measurement. Because I strongly believe that, all said and done, implementation of standardized blood pressure measurement is difficult. And so across the world, most clinicians will have to depend on routine blood pressure measurement to treat their patients. And I'll leave you with the conclusion from our paper that I and Carmine Zuccali wrote in Hypertension recently, essentially describing or concluding what I've already said to you. I'll leave that with you to decide whether you really feel that KDIGO systolic blood pressure less than 120 millimeter of mercury for chronic kidney disease is appropriate in routine clinical practice. Thank you.
Well, thank you both for this very nice presentations and for the arguments. And we are now very, very curious how Professor Mann is arguing against the arguments of Professor Dasgupta. First off, we would probably limit it to 3 to 5 minutes, something like that.
Thanks, Indranil, for this wonderful talk, which shows the problems that we have in daily life. Yeah, when we see our patients, I presented more so the overview, and you really went to the patient. I just want to get one step back and say what we really need is more data. I think it's appalling if we see that billions, really billions, are spent on new diabetes treatments and how they work in patients with CKD. We have spent hundreds of millions, including ourselves, on inhibitors of the renal system and CKD. And we have only very, very restricted data on which target is important. Yeah, that's appalling, I think. And therefore, what we both did not discuss, but what is important, that when we have the patient in front, we have to individualize treatment. It's a guideline. I mean, that's not a law. It's a guideline. And individualization is really key. Now, when we thought of it, we worked on it for 2 years and spent a lot of time on it. What would be the alternative? I mean, giving no hints, no data, and setting no targets. This was the other argument. We also discussed what the Australians were saying, below 140 for everybody and below 120 if feasible, and please try to. But this was opposed by the majority because then everybody would just go below 140 and that's it. And there is this survival benefit in sprint. Polypharmacy is a problem. There is a solution. I'm part of the TIPS-3 team, which tested a pill that contains 4 different antihypertensive. It was published in New England Journal 1.5 years ago. And I can tell you that in the CKD subgroup of TIPS, the polypill was especially effective in those with CKD as compared to those with non-CKD. And remember, TIPS-3, we did TIPS-3 in low and middle income countries. So India, Indonesia, Tanzania, a few people from Canada, this was it, but the rest was in Asia and in Africa. So that's surmountable. For the measurement, I'm using in my clinic, and we are using in my clinic, and it's a busy clinic. We are using standardized measurement now for, since Sprint was published, for 7 years. We do it with an automatic machine, and it saves a lot of time because the machine is doing everything. We are just hooking up the cuff, and then we leave, or we do our work, but we don't talk to the patient. And that's feasible. We do it because actually all trials, I mean, every single trial, randomized controlled trial in hypertension was done with this technique and was not done by routine blood pressure. That's the problem of translating routine to standardized blood pressure. And if you look at the mean differences between the two, then the goal of range of 135 and 120 is just the one with routine and the other one with standardized blood pressure. Thanks.
No, absolutely. I agree with most points you've mentioned, Hans, and especially the last one, that perhaps on the basis of what we know, and also basis of a meta-analysis, which I'm sure you've seen, of 35 hypertension trials by Bangalore et al., which was published last year, and which showed that if you look at risk-benefit ratio, and so they did beautifully the risk and benefit calculated for each of the targets for the whole trial, for all 30 plus trials, and they found that the line goes through around 130. So if you balance, benefit and harm, this probably 130 is probably looks like from this, and of course these are meta-analysis, looks like 130 is the line. We should, that has got the least harm and maximum benefit. Yes, if you go down to 120, you've got more benefit. It's no doubt about it, but also the harm increases. So that's an issue. And in fact, we did after NICE guidelines were published last year, we did a commentary for the UK Renal Association, and exactly that's what he said, that we should be aiming for 130 rather than 140, as Marx, as NICE suggested, that we should be aiming for less than 130. And perhaps we should also have a diastolic lower limit of around 80, so that we don't push it too low. So that I agree with, and I also agree completely with you that we need a shared decision making with the patient, explain what are the harms are likely to be, what the benefits are, and then say, are you happy to, for us to try and get your blood pressure down to 120? And many patients, because the people that have encountered the problems of low blood pressures, and if you think of our dialysis patients, the people that get high interdialytic hypertension, they dread that. They absolutely dread it. And so, just to explain to them what to expect, I think that would be really, really very helpful. And I think that's what we need. And more than that, there are two other things I want to say. One is that one thing we have learned post-COVID or over the pandemic, that many people with chronic diseases will probably in the future be monitored, virtually, and for that we need reliable blood pressure, and of course GFR and SCR to be done in community probably. So I personally believe we need a target based on home blood pressure, and the patients need to be taught how to do standardized blood pressure themselves. And if we could do a trial, I think this is extremely optimistic, that if we could do a trial of stage 4, 3, 4, 5 CKD with the intensive and usual blood pressure control arms, using home blood pressure monitoring in a standardized fashion, that is what is going to give us the answer. So I agree with you, we don't have the answer. And because you don't have the answer, I'm unkeen on, I cannot suggest we do something that might harm our patients, because again, I said, it hinges on implementation of standardized blood pressure measurement. And across the world, in the primary care, that's where our CKD patients are. And in resource poor settings in developing countries, they find it very hard to implement, and so they'll have to rely on routine blood pressure, which means the patients will come to harm, because if they target 120 systolic based on routine blood pressure, as you've said, and you agree with me, and I agree with you completely, those patients will fall and have fractures and all sorts of problems. So I think we agree in most points, but we also I do sincerely believe we need a trial of 2 targets in people with CKD. Now, you might argue we need a similar trial for our dialysis patients as well, but CKD certainly.
CKD certainly, that's first.
Yes, and to get the answer to have the, and then we can't argue with that. We wouldn't be able to argue with that if we had that.
That has been a great discussion, I think, and you can of course continue, because we are listening a lot of passion here, and see that the points are not that clear cut. So basically there is a certain mixture of opinions and coming together. I think that's very important. I guess that the idea to perform a trial with outpatient blood pressure monitoring would be really nice, and I think you would find probably funding here as well by NHR, HTA or something like that, because this is really a massive investment here and can reduce the burden of patients coming to see you in a clinic, and that would be really nice, and cost saving as well for the NHS or for national insurances. So, well, you've taken away a lot of potential questions we prepared up front, but one which is coming into my mind early on is, of course, that patients with glomerulonephritis on immunosuppression have been excluded not only from the hypertension trials, but also, for instance, from the SGLT2 inhibitor trials. But these patients are usually presenting with a very difficult to treat hypertension because of their steroids and other immunosuppressants used. So how do you manage these patients? What is your target here during active therapy? Because these patients are also at a very high risk of cardiovascular events.
Indranil, do you want to jump in first?
Yeah, I mean, again, because the evidence is so thin, it is very hard to recommend anything. What I personally, again, this is, you might call it my bias, but from the basis of all the different studies that we have, quite clearly there is no evidence for benefit of 120, systolic of 120 or less in these people. So 130 probably is what we should be aiming for, less 130 and less rather than 130 and above, 130 and less for people with, but then this is based on hodgepodge of studies and trials because there isn't a single trial to support that. So that's my personal view. But particularly so because SPRINT excluded these people.
Yeah, I agree to be, let's say, aggressive on the blood pressure of these patients and target below 130 and reaching this target in this population particularly is also my advice. And I'm saying so because there is evidence that the glomerulus in these situations is particularly sensitive to blood pressure. Remember that the blood pressure itself can provoke, in particular patients, crescents. I remember a patient that opened my mind to that, got children's kidney. So a child died in an accident, and an adult patient got the two kidneys, and blood pressure was not very high. Let's say in the range of, I have forgotten that, but the blood pressure, but then we lowered it, let's say in the 110, 100 range that the kidneys experienced before. And the crescents that were seen were completely lost only by lowering blood pressure. And there are other data that to that, and therefore that's my advice, to lower the blood pressure.
Yeah, I don't argue with that. It's just that what is the target? There are people with glomerulonephritis that are either being treated or likely to be treated with immunosuppression actually have one of the most rapid decline in kidney function over time. And hence these people are likely to benefit, but we haven't from strict control, but we don't have any evidence, and hence we have to go with what evidence we have so far, and which, in my opinion, is probably 130 systolic or less.
So the next clinical trial we need to set up, I guess, in future. One of the questions also we have prepared for this talk is, and Professor Mann is certainly aware of that, the German CKD trial has done a sub-study focusing on blood pressure. And what they found is, and this is a bit in line with what Professor Dasgupta has told us, that around 50% of their patients has been identified as having resistant hypertension. That was defined as 3 antihypertensive drugs, including one diuretic. And this is also what we are seeing in clinical practice. So how would you best approach this patient to achieve a blood pressure, let's say below 130 or even below 120, because in my mind, it's often unrealistic.
We have lots of patients with resistant hypertension. CKD was a purely observational study, and I'm not certain whether I'm not part of the study, whether the technique of measuring blood pressure was defined or whether it was routine blood pressure. I assume it was routine blood pressure in that study. So we have to translate it, which you can on a population level. You can't on the individual level, but you can on the population level. That said, we frequently have such patients. And number one, when I discuss it with fellows, is appropriate natriuresis in the patient first. And there was a wonderful study, a small study by Rajiv Agarwal, testing chlorthalidone. It's one of my favorite diuretics, 25 milligrams in patients with CKD and poorly controlled blood pressure. And it was highly effective. And since he has published, I'm also trying, I'm using chlorthalidone and dopamide as my standard diuretics, but not in CKD patients with the GFR less than 40 that were included in Rajiv's trial. But it works. It works on blood pressure. The mean decrease was 11 millimeters of mercury in Rajiv's study. And it works to an extent that you have to look after the patients because of too much diuretic treatment in some. And that's number one. And number two is to look for the appropriate mixture of antihypertensives. Yeah. I mean, the combination of beta blocker with an ACE inhibitor is not ideal as far as blood pressure is concerned and things like that. But number one is adequate diuresis and also spironolactone or eplerenone whenever potassium is 4 or below 4 millimoles per liter.
No, I agree with your approach, actually. So what I do in practice for people who are apparently treatment resistant, needing 3 or more drugs, and not achieving blood pressure target, whatever it is, 130 generally for me. What I do, the first thing I do, because I am a huge believer that most of the people that do not achieve blood pressure target is because they don't take their tablets. And I've shown it in 2 ways, by directly observed therapy and also by urine assay. So my practice since 2016, since I managed to establish a urine assay in my hospital, my practice is to send their urine for a drug assay to see if they're taking their tablets. And as I said, 50% of them either don't take at all or take some of the tablets, but not all. Maybe one I can, and if you get a chance to talk face to face one day, Hans, I'll tell you a few stories of how people, patients hide or try to hide the fact that they're not taking. So that's the first thing I do. I also, at the same time, I also do an ABPM because, again, I believe that there's a lot of white coat hypertension even in people with CKD, although they also have mast hypertension, and that's another reason why you need to do ABPM in people with hypertension not controlling, controlled with 3 drugs. The next thing I do is rationalize, as you've said. If they're an ACE, quite often they're on irrational combination. So. Ideally, we should be going with ACE ARB at maximum tolerated dose, then calcium channel blocker maximum tolerated dose, and a diuretic, etc. So that's what I do: rationalize and then add further tablets and spironolactone quite often. And thereby, only very few patients then they're left that blood pressure is not controlled to at least 130/80. Following this. The other interesting observation in response to natriuresis, Hans, is that you will see these people, when they go on dialysis, suddenly their blood pressure melts away. They come off tablets because now we are able to remove fluid and salt effectively, and hence their blood pressure does not remain a problem. And that's absolutely supports your view that is a lot of it's natriuresis. But I must say I was quite surprised with Rajiv's study, simply because I was under the impression, I was taught all my life that the thiazide diuretics don't work if your GFR is below 30. You know, it's because there are not enough tubules functioning to respond to, but that's not true, clearly.
It's not true. And it's a very cheap drug in comparison to what we get of new drugs on the market. Yeah, absolutely.
Exactly.
Yeah, absolutely. What I do for compliance is, so I like ACE inhibitors because they can measure ACE. And if ACE is not low, the patient has not taken it. And I measure diuretics in the urines because it's easy, it's cheap.
Well, you need to, I think what we need to do is difficult, of course. If the lab has mass spectroscopy, you can adapt that to do urine drug assay. It doesn't cost a lot of money. I mean, it does initially if they have the mass spec machine. The rest is not that costly. You just, somebody needs to, you know, take the initiative, preferably a biochemist. But it's really helpful and it's revealing. You know, how patients we think are, you know, people, you cannot trust anyone, you know, people that are teachers or doctors or even, you know, people that are educated. And you think they take the tablets. No, they don't. Quite often they don't.
Yeah, that's quite funny. I mean, we all know our patients quite well, I guess. And the more education, I think it's usually the more complicated they are in different aspects, of course. So I think that's it from my side. I'm handing over to Gunnar now.
Yeah, so I would have 2 or 3 final questions for each of you. And the first one actually would be a strategic question, Dr. Mann. So both of you showed us these slides with all these different guidelines and the European cardiological guidelines going for 130 up to 140, which is not really a good suggestion, I think. Then we come with KDIGO below 120. If I got it right, KDIGO plans to update these guidelines now on an annual basis or so. But wouldn't it be wiser to really try to bring all these societies together and to try to get one recommendation for CKD patients for Europe, from the States, from Asia, or is this just a naive suggestion from me?
Sorry to say that it's not feasible, for one, yeah. And second, it's normal that they have the same data, but we interpret it differently. That's the way it is. We are now actually far advanced in bringing a lot of these societies, in particular the ones you were talking about, together to issue a statement of the importance of standardized measurement of blood pressure whenever you manage blood pressure. That's the only thing we will discuss in that paper. Let's see who accepts to publish it. But we brought a large number of societies from South America, from North America, from the European side, from European countries, from low middle income countries, from patient association together. And just last Tuesday, we were discussing the first full draft of the 5 chapters of that statement that we will issue.
So my second question to you would be, I see a lot of patients here with CKD who come to our office who have a blood pressure of, say, 125 or something, and we really try to have kind of a standardized office BP measurements. I guess we're not perfect in that, but we really try to take our time and so on. And these patients show us their home readings, and they have at home blood pressure readings of, say, 110, 105. Should we really in these patients go for even stricter medication when they do their home measurements and when they are at home really well below 120?
There's unfortunately not a single trial that tells us what to do and how to guide the patient. What I think is important to teach the patient to measure blood pressure at home the same we do it standardized version. So that he's calm for a few minutes and then takes his blood pressure several times. But the case you are describing obviously happens, and it's a personal decision. There's nothing you can say based on guidelines. If you go along the huge studies, none of those studies ever looked at home blood pressure measurement or ambulatory blood pressures, except in sub-studies. There are a few sub-studies done, but not the big trials themselves.
So my last question to you, which is actually not my question, but an argument that has been raised time and again, is that even in sprint, the mean achieved blood pressure was not below 120. It was, if I remember correctly, 122. So the majority of patients in the intensive blood pressure arm were actually above 120. So against this background, again, are we not quite strict by trying to go below 120?
Well, for this you have to understand, I mean, you understand it, but you have to keep in mind what's the target blood pressure and what's achieved blood pressure. There's a huge difference. And a trial that is setting to achieve a blood pressure below 120 and reaches 121, it's not bad, really. If you think of the low salt studies where they want to achieve an intake below 2 grams, and the mean achieved is 3.5 or 4 grams. Yeah. That's really a huge difference between the target and the achieved. But here we are pretty close. So that's not too bad. And so the mean achieved does not contradict the target, to put it this way. That's my take.
So then my last questions to Indy would also, for the first question, be a strategic question. So we now have, after years of discussion with KDIGO, this recommendation to go below 120. If we now start to rediscuss this issue and say now, well, maybe it's just too strict, and I just saw the KDIGO recommendations from the states, which also say, well, maybe 130 would be better. Are we not kind of losing our colleagues who really get the impression that we have actually no idea what to do if we kind of leave these recommendations? Should we not stand by the results of this KDIGO process?
Well, once again, as quite rightly Hans said, that it's a matter of interpretation, how you're interpreting the evidence, and similarly how you are interpreting a guideline. Now, guidelines are guidance. This is not something that is a gospel. It's not you have to listen to, or you decide depending on your patient in front of you, what target you should be aiming for. But that's, I agree completely that KDIGO, I saw that as well there last night. They're suggesting 130 may be a better target, and I just wonder whether KDIGO should listen to all these various bodies and maybe go back in a couple of years' time or a year's time and look at the what the real world situation is. Are people achieving this blood pressure target? Are there any harms from this blood pressure targets applied again to routine blood pressure target, as is quite likely? So is there any mechanism, I don't know, Hans would know, if just to go back and review the situation in a year or a couple of years' time to see, is that the right blood pressure target? Are we gaining much by following this, or should we be retracting to something that's safer generally?
So the second question would be, you said that we should be afraid of lowering the diastolic blood pressure too low because there may be a potential risk behind it. But to my best understanding, this is purely association, and nobody ever has shown that by reducing blood pressure in a randomized way, below a certain given diastolic blood pressure range that we really put our patients at risk. So should a diastolic blood pressure of, say, below 60 or so really be something that should stop us in intensifying the medication, or should we just accept these measurements?
So a very good point, actually. The thing is, yes, you're right. These are all association. The slide that I showed, but I didn't get a chance to describe, is from Framingham group. So this is a Framingham, follow-up study looking at people that had naturally low diastolic blood pressure below 70, and those who had low diastolic below 70 with treatment. And they showed elegantly that in both groups, there was increase in cardiovascular events compared to those who had a diastolic blood pressure over 80. Now, the problem is, of course, there will never be a RCT of diastolic blood pressure. It's most unlikely, below 70 and over 80 or something.
Not anymore.
And so I don't think we'll ever have the answer, from a randomized controlled trial. Now, in a way, it's whether you believe in physiology that you need a certain diastolic blood pressure for coronary artery filling. If that's what we've been taught and we believe, in the physiologically correct thing, then the association could be right. So yes, I agree, it's association, but I don't know of, and I don't think there'll ever be a RCT of diastolic blood pressure targets.
The very last question. So you put some importance on the polypharmacy, which surely is a problem, but I'm aware that quite a lot of medication our patients are taking are less evidence-based than blood pressure medication. So all this gastric pills and things to lower uric acid and stuff like that. But now we have the SGLT2 inhibitors, and we are quite soon getting the novel aldosterone receptor blockers. Do you believe that this may affect the discussion of blood pressure targets? So once we have SGLT2 inhibitors and finerenone in the majority of our patients, should we rediscuss blood pressure targets, or will this not affect actually this discussion?
Very good question again, and difficult to answer. The thing is, you'd expect these to be additive. So lowering blood pressure using ACE-ARB, SGLT2, and then finerenone, if they all individually reduce the risk of cardiovascular events and also and slowing progression of kidney disease. So they should be additive. It's again, unless we do a trial, we'll never know. So a trial of blood pressure control in whatever way, and the other with blood pressure loosely controlled with all these new agents and ACE-ARB, that will be the only way to answer that question. That do we really need to go as low as 120 or even 130 when we have other new agents that are beneficial, to the kidney and also for cardiovascular risk.
Thanks a lot. This was really fantastic. I think we agree on the majority of issues, and for the vast majority of patients, we have a good way to go to really get the target blood pressure targets, whether they are 120 or 130, as we are aware that the majority of patients are actually far above these targets anyway. So much work to be done. Thanks a lot for being our guests today, and it was really a privilege to have you. Thank you.
Thank you very much for inviting me.
Bye.